So I just wanted to mention about Echo. This is all these little green dots here are the different Echo hubs. So you can see here that we have in North Dakota, the Grand Forks Echo Hub at University of North Dakota. And the idea is that the Echo philosophy is that we all teach and we all learn from each other. And so that's why it's so important to have input and feedback through the chat box, or if you can unmute yourself and make comments as we roll along here. That's all part of the philosophy for helping each other towards a better understanding and knowledge of quality improvement. The important part of it, like QAPI, is that we want to apply the current and best practices. And so I've been doing my level best to try to identify information from the COVID research. We're actually involved in COVID research ourselves in terms of the post-COVID syndrome. So we're trying to bring whatever is cutting edge to this coalition so that we're all up to date with the best information possible. And we also proceed with case-based learning. So you'll see that there'll be specific examples, and you'll be asked to respond to those cases and give feedback as to how you would handle it in your circumstances. Next slide, please. So the overall coalition or action coalition for COVID, the goal is to try to obviously keep COVID out of the nursing homes. We want to identify those that do have COVID, and we want to further prevent the spread of COVID, particularly with the horizon of these new variants showing up. We really feel like it's going to be like influenza. It's just going to be waves and waves of outbreaks that we're going to need to deal with. So trying to get a handle on that is going to be an important goal. Next slide, please. The other goals for this project are to provide safe and appropriate care for residents, particularly those with mild and asymptomatic infections. We want to make sure that the staff have the knowledge and skills, as well as the confidence to implement what we're calling best practices for both safety and protecting themselves, their families, and the residents. And then finally, we want to look at different ideas for reducing social isolation as we're having to deal with quarantines and other measures that prevent our normal socialization. We have a whole series on presentations on that topic. Next slide, please. So I just really want to quickly go through these. These are the different topics that we're going to go. So today is just a general introduction on the approach to COVID prevention. And then we're going to go through topic by topic that you can see here. Next slide, please. Some further topics, weeks 6 through 10. These are all basically, and then the following ones going through week 16, which, do we have one more slide on week 16? Maybe not. No, oh, the numbers are wrong. What do you know? There's 2 13s and 2 14s. So these are supposed to be 15 and 16. So you can see the different topics that we're going to have. Sometimes we'll add a more timely topic, like we'll interject vaccination, for example, when that became a more important issue during these sessions. Next slide, please. So the format that we go through is that we, as I mentioned, we have a pre-session knowledge survey. We'll usually cover an infection control topic, followed with questions and answers. Those presentations will either be a video or a PowerPoint presentation plus a video or other formats. So we're going to mix those up. And these are resources from the national collaboration. These all come from, all the content for this is from the Institute for Healthcare Improvement, which is actually an international organization for quality improvement. So the second half of these sessions then hone in or focus on the quality improvement process. And again, followed by questions and answers. So a lot of times we'll ask you to fill into the chat box what your thoughts are. If you're bold enough, if you will, to unmute yourself and offer your wisdom through, by just speaking to the group. that is highly encouraged. And so we really appreciate that when you do speak out. Next slide, please. So our expectations are is that that your team, again, minimum of 2, we prefer 4, attend these sessions. We've purposefully scheduled them at noon as a point of juncture and convenience for nursing home staff. And you can see the 4 members here that we would like to have. I'll be perfectly honest with you, a lot of our medical directors have been AWOL, and so we're hoping to get them more engaged in this project to really ramp up the efforts for QAPI. And then you can also, if one of your individual team members or other members miss a particular session, they can go to our Dakota Geriatrics website and view the session online at their convenience. You can't use that, just to let you know, for the reimbursement mechanism. You can't use these makeup videos as a regular process. You have to attend the live sessions, but we understand that some people, either because of sickness or vacation or time off, may need to make up these videos. And if you do so, please let our team know that you've done that so we can give you credit for that. Next slide, please. And the other expectations is that I have a little logo here for the chat box, is that we have folks share their quality improvement projects. These are really important. So if you have a PIP on the books, we'd like you to basically route those to us so we can take a peek at them and help critique and share what works and what doesn't work in those particular PIPs. So we're looking for you to send us examples of your PIPs. We also look for examples of providing case reports. So if you had some unusual circumstance that, let's say 3 people were sent out of the facility with delirium and 2 out of the 3 had COVID as a consequence, we want to hear about that and then share that information and discuss things like atypical presentation of common illnesses in older adults. And likewise, we want to share root cause analysis. So if you have an outbreak in the facility, what was the root cause analysis? What was the tracking, and what can we learn from that particular incident? Next slide, please. Yeah, I just wanted to point out, and we'll go over this again, some of the resources. So probably the big one for everybody to recognize is that top one is the Dakota Geriatrics. You can just Google it and it'll take you to the website. And that's where we archive and house all of these sessions. The other second, probably most important resource is the Institute for Healthcare Improvement. You can see where they have what's called the ECHO CAN, C-A-N, that you can type that into their search engine, and you'll get all the resources that they've collected for the ECHO CAN program. Okay. Somebody asked a question, why are you excluding DON from your list? I didn't mean to do that. I think I had directors of nursing on there. I'll take a look at the slide and fix it if it is. So that was not a omission by any stretch there. We do want the directors of nursing, and we want the individuals from quality improvement, infection control, the medical director, and the administrator. So thank you for bringing that point up. Next slide. I think we have the video next, right?
While Casey's pulling up that video, I just wanted to tag on to Dr. Juravich's comment about sharing and everybody learning together. We really would love people to provide any case-specific situations that you have, good or bad, to share with the group and see if we can all work together to kind of create a plan for that. We developed some sample case studies to talk through, but it would be nice if we had a real life one that we could work through with you all. So just keep that in mind as we go through this program.
Yeah, I agree, Kelly. So just to remind everybody, Kelly is one of our 2 quality improvement officers. Kelly's representing the Institute for Healthcare Improvement, and Michelle Lochner is our homegrown quality improvement officer from the Quality Health Associates group, the Great Plains Quality Health Associates. Oh, it looks like we're starting to get the video. Good.
All right, here we go.
Excellent. Thank you. And our apologies for the glitch here.
Hello, and welcome to this fast-paced presentation on COVID-19, Stopping the Spread. We are going to highlight actions to take and highlighting some key strategies for screening and testing today. We know that an essential component of the prevention of spread is to prevent the virus from entering your facility. Good screening in combination with testing are essential components for success. My name is Lisa Thompson, and I'm the Chief Strategy Officer for Pathway Health. And also joining me today is Sue LaGrange. She's the Director of Education, and she leads the COVID Task Force for Pathway Health Service and is also a board-certified infection preventionist.
In order to put in place a good system, putting together a team of professionals will help you to review all expected state and federal guidance, then to develop policies and procedures, identify necessary supplies that are going to be needed, and then contact vendors to access those supplies, provide initial and ongoing education to the employees, and then monitor for compliance. Education will need to be done initially and ongoing, and needs to include the entire process, from equipment use, when to test, how to collect specimens, PPE, personal protective equipment necessary, hand hygiene, how to read results, reporting, cleaning and disinfection, and what they're supposed to do with a positive result. So it's going to be important to assign authority for the whole process.
Another aspect in stopping the spread in our organizations is the part of preventing the spread is to prevent the virus from entering the building at all, and that's screening. So that means screening of employees, visitors, vendors, contract staff, and those alike. It's very crucial to success. Screening must be active screening, meaning staff cannot self-screen. Also, when we look at this and when we're doing the screening process, we know we look at signs and symptoms, but one thing is key to remember is that fever is defined as 100 degrees or higher for staff or for residents. And a temperature of 100 degrees Fahrenheit or more than 2 temperatures above 99 degrees Fahrenheit is also considered a fever. So again, making sure that we have up-to-date screening tools and we're actively screening our residents, our staff, and visitors or vendors, and making sure that we're following the key components and we're not self-screening.
There are several different types of testing. There's diagnostic testings for SARS-CoV-2, which is coronavirus or COVID-19, and that's intended to identify current infection in individuals and is performed when a resident or person or staff member has signs or symptoms that's consistent with COVID-19, or if someone is asymptomatic but had recent exposure or suspected exposure to COVID-19. Next is screening testing. And this for COVID is intended to identify infected persons who are asymptomatic without known or suspected exposure to COVID-19 or SARS-CoV-2. Screening testing is performed in order to identify persons who may be contagious so that measures can be taken to prevent further transmission. The CDC also talks about surveillance testing, which is strictly used for public health surveillance. So we won't be talking about that today.
And we also know part of the testing protocol is looking at the rapid antigen testing. And we know it can be used at point of care. And we also know how quickly we can get the results within about 15 minutes. And it can be used for screening in high-risk settings, such as in our communal settings and long-term care, and all allows for prompt implementation of our infection prevention and control measures in order to prevent spread within our organizations. So we know facilities, we've received our rapid antigen devices for point of care rapid antigen testing. And generally we know that they're less sensitive than the viral testing that really detects the nucleic acid using. So that's part of that, the RT-PCR testing. And we also know it performs best when individuals tested in the early stages of COVID-19 infections. That means the viral load is generally at its highest.
For employee testing or staff testing, it is completed for staff that have signs or symptoms of COVID-19 based upon screening, or if an employee indicates that they now have symptoms. Asymptomatic staff also with known or suspected exposure, whether it is inside or outside the facility. Also, staff testing is completed for asymptomatic staff according to routine testing by the community COVID-19 positivity rate. Staff testing is also completed for staff who have been diagnosed with COVID-19 to determine if no longer infectious, only in some cases, because the CDC does indicate that a test-based strategy is no longer recommended, such as someone who is severely immunocompromised, because in the majority of cases, it results in excluding from work the healthcare personnel who continue to shed detectable SARS-CoV-2 RNA, but they are no longer infectious.
And we know there are 3 triggers for testing. When there's a asymptomatic individual identified, and any new cases in the facility, even one case is considered an outbreak for COVID-19, and routine testing in accordance with CMS guidance. So again, you can see the testing, the triggers that they're on the far left-hand side. So for outbreak testing, all staff and residents should be tested, and all staff and residents that tested negative should be retested every 3 to 7 days until the testing identifies no new cases of COVID-19 infection among staff or residents for a period of at least 14 days since the most recent positive result. For more information, please review, the section that is entitled in the document that you can see here, and the link that there's a section in the QSO memo that goes into more specific details.
It is also documented that when there are significant cases of COVID-19 in the county or in the community, the chances of COVID-19 coming into your building, sometimes by asymptomatic staff who unknowingly bring it in, is higher. This is why routine testing is determined by the community COVID-19 activity level. And as you can see, there is a graph on the slide that indicates the minimum testing frequency based on the county positivity rate in the past week.
And you can see here on the slide here, there's the link to a great website for all of us to go back to and refer to, because CDC indicates that all testing for SARS-CoV-2, including the rapid antigen testing, is directly impacted by the integrity of the specimen, which really depends on specimen collection and handling. So this website is available to us, and it's very essential that whoever is collecting the specimens for testing is donning the most appropriate PPE, and that needs to include, first, perform hand hygiene, then don your gloves, gown, N95 respirator, and face shield or goggles.
Next is follow-up with the test results. Immediate placement decision for a resident. For example, placing a resident on a COVID-19 positive unit on precautions if symptoms and a confirmed positive test. We will discuss that more on the next slide. For employees, we would send them home immediately and work with employee health for follow-up. And then notifications, physician, resident representative, and other reporting, public health, CLIA, NHSN, all residents and representatives per facility leadership. Retesting in accordance with the tables discussed earlier. And also the facility plan for new cases, room moves, and emergency staffing. I do want to indicate that follow up with test results, when we're looking at that immediate placement decision for a resident, it is important that before we put them on a COVID-19 unit, that we do have a verification of that confirmed test result.
And another strategy for stopping the spread in your organization is resident placement, as Sue talked about, and making sure we have that good, solid testing strategy in place. That resident placement is having that need of a dedicated space or location for your COVID-19 care unit and a staffing plan for dedicated staff or consistent assignment with their own restroom, break room, and other work area that is separate from those caring for the other residents in your organization. Dedicated equipment is essential for this unit as well. It should be cleaned and disinfected if using in between residents on the COVID-19 care unit. And for any exposed residents, new residents, or suspected residents, until testing is completed, residents should be quarantined. Private room with their own bathroom, ideally on a quarantine unit or a space with no cohorting.
Additional measures, as Lisa indicated, consistent assignment and dedicated staff is essential, but it's also important that if you have housekeeping, that they are also dedicated to that unit with the same break room and employee restroom as well. PPE use in accordance with the best practice approach with CDC and your facility policy and procedure, and following CDC's optimization guidance. Next, hand hygiene, hand hygiene, hand hygiene. It's important that staff are following good hand hygiene. And then cleaning and disinfection in accordance with best practices using EPA registered list and against SARS-CoV-2, which is COVID-19. And of course, making sure facility staff are following all of your policies and procedures with COVID-19.
So in summary, with our short little presentation here on stopping the spread, early identification of an employee or resident is crucial in the prevention of the spread of COVID-19 in long-term care facilities. Active screening for all and testing in accordance with the most recent guidance will provide information to put prompt mitigation steps in place in order to stop the spread. Sue and I want to thank you today for participating in this presentation on some key strategies on stopping the spread within your organization.
Very good. I wanted to address one of the points in this slide deck. So we had Erica Clemens mentioned that the Department of Health guidelines was a 100.4 temperature or greater as a cutoff for febrile responses to respond to for COVID testing or suspected quarantine or isolation. And so the point that I think we want to make is that a change in temperature should put the yellow lights on, and the precision by which you measure the temperature. I mean, temperatures can be off by 0.1, 0.2 degrees Fahrenheit. You take the temperature again, 2 minutes later, you're going to get yet another temperature. I think the key point is that if you have somebody with an elevated temperature, you really have to think seriously about infection, whether it be COVID, influenza, respiratory syncytial virus, or other types of infection. I mean, it could be a urinary tract infection for that matter. And I was going to ask, is Faye Salzer on the call today?
No, she's not able to join us on Fridays.
Yeah. Okay. So I will ask Faye, who's from the Department of Health. She's usually on these calls to see if there's any additional clarification about that. But I think a key point in terms of the residents, the commentary was that using a temperature of 99.6 as a potential fever in residents, and if they're immunocompromised, well, that quite honestly, if they're frail. Or older, like over the age of 90, for example, a temperature of 99 could represent a fever. And the important consideration there is to look at their basal temperatures over time. So if they're running 96.8 Fahrenheit, it could be that a 99 flat temperature for them is a fever. So I guess while we're using these guidelines for temperature, there's no precise cutoff. It's important to just take it in the context of whether there's some additional symptoms along with the fever. And typically, if you do have a fever, there'll be things like sore throat, cough, and shortness of breath. It's more like the people who don't have much of a fever or who are afebrile but have nasal congestion or have falls or have confusion. Those are the people that we need to think about, screening for COVID and moving forward on that. So thank you, Erica, for that question. That's wonderful. Let's move on to the case study here. Here we go.
So as all of you know, that with COVID, the restrictions have been adjusted to visitors coming in and out of the facility, and those can be family members, caregivers, essential caregivers. You also look at even vendors coming in. So maybe your hospice reps or home health reps, the ones that like to come by and drop off goodies for you on a regular basis. So in this case study, we're going to talk a little bit about visitors, and we have a couple of questions as follow-up to kind of get your input on what you guys are doing. So I think we can go ahead and go to the next slide. In some states, they are relaxing guidelines. I know that when we first did this presentation, we were kind of in that time frame, and then we had a spike again, and everyone was tightening up on the guidelines. And so it's starting to open up a little more now again. But the guidelines about indoor visitations, you would have certain protocols. The staff, the owners, and local leaders have raised concerns about indoor visits and the possibility of raising the risk of infection for both residents and staff. So as I mentioned, we have a couple of questions for discussion, and we would love you all to chat in. And I do appreciate that we've already had some conversations on chat so far during the presentation. So with the adjustments to the restrictions of visitors, how would you approach writing, or how did you approach writing guidelines or protocols for indoor visitations for your facility? And you also are welcome to come off of mute and discuss what you've done in regards to visitation, a best practice possibly that can be shared with some of your peers, if anybody has something they'd like to share. And while we're waiting on someone either to chat or come off mute, I'll give one example. I had a facility that I was working with on a different project who they did visits outside the facility, but they had the residents, they got in their van, they drove to the local park, and they used their cell phones for their families were in their car, the residents were in the van, and they were able to talk back and forth. It was an opportunity for the resident to get out of the facility, still to visit with their family in an open area, and just to try to think of something different to keep them their spirits up. But what if anybody has any specific guidelines that you're using, with the exception of the typical screening for indoor visits?
Yeah, so maybe one way to start that off, Kelly, if you can put in the chat box whether you allow indoor visits separately from the compassionate care visits. Just type in the box yes or no. So the question is, do you do indoor visits in addition to the compassionate care visits?
Yeah, we've got some yeses.
Yeah.
And it's very cold up there. I think indoor visits are probably necessary for you guys.
Yeah, so an interesting point from Ann, just talking about the positivity rate on the county will guide whether they have indoor visits or not. That's really excellent. Yeah, so obviously there's a policy of restrictions. Yeah, if there's an outbreak, you don't want to be, so you have to dismantle the visit program. So that all should be part of a policy that you write down, right?
Yeah, Christine just wrote too that she's writing a plan right now, if you're willing to share what you're doing.
Great. Yeah, so we have facility-specific policies, and I think that that's the important part, is to consider when you do change the policies, that the policy is updated, I think is an important point, right, Kelly?
Absolutely, making sure it's updated and making sure that the facility staff and families are aware of what that policy is, as well as the residents, so that there's not a question when they're following through. And just going through and asking staff and family members and residents the simple questions: are you aware of what the policy is now? And see what kind of feedback you get. And really, by just doing those brief interviews with staff and residents, you get a feel for what everyone understands, and you may need to adjust your training or education to those folks accordingly.
Yeah, yeah, and it's important. So one of the other parts of the policy is when you have these visits, we asked the question of another group of nursing home participants as to whether they restrict age, like, is anybody under the age of 12, under the age of 18, for example, admitted to the facility as a visitor. And so there was differences in their policies. So one policy was, yes, they would allow younger children if they were able to wear a mask or demonstrate the ability to wear a mask, and others had hard cutoffs at, for instance, 12 and under. So these are all good points. Thank you for the feedback on these. I think we can see these examples. The key point for quality improvement is to constantly monitor the efficacy of these. And so some of the screening measures, I see somebody's using pretty much a required antigen testing for visitors before they enter the facility. If you have those resources, that's good. We actually created a PIP for looking at a sniff test as an additional screen of testing. So people would be, their temperature would be taken, they go through the list of symptoms, and they would also additionally have to be asked to sniff a sample to identify what the scent was, as an added layer of screening. Good.
Thanks for sharing too, Christine. You said you were writing your plan now, and I see that you've shared that in the chat. And for those of you that are still trying to work on a plan, say you're not doing indoor visits right now due to your outbreak or such, then you can kind of get some ideas from your peers here on what works for them. And Dixie, I see that you are alerting staff and families by phone with each change in policy. And I've had facilities talk about too, they have some kind of social media platform that they notify families of any policy changes, or an blast email or whatever. Just really the point of this is that you have some way to communicate it. It doesn't really matter how you're communicating, but as long as you have something in your plan of how you're communicating it to those folks.
Yeah.
Okay, we can go to the next discussion question. Thanks guys for responding. That's awesome. How would you reassure staff, families, and residents that indoor visits will be made as safe as possible? I think something interesting that just popped in my head about this question is, here lately we've been working so hard at making staff, families, and residents feel comfortable with the vaccine. So whenever you were doing visitations too, you were probably having to communicate some of the same things. What are we putting in place to make sure it's safe? And I know that a lot of you are communicating change in policy, but also to include information about how that's safe and how you came up with the plan. And when we talk about quality improvement, we talk about small tests of change whenever you put a plan in place. So for example, on this visitation, if you put your plan in place, and Christine, you said you had just started writing your plan, test that on a small area. And then when you're trying to reassure the staff, family, and residents, you can say, you know what, this was our plan. We tested it on a small group. And this is why we know this plan is going to be successful, because we've tested it. And so we'll talk more in depth throughout this program about some of those tests of change and how you can monitor that. But it is a good way to reassure those families and residents and staff that your process policy is a reliable one. and screening for sure. I think we talk about screening later on as well, how we can test the reliability of your screening process too.
Yeah, and I like the comment about the ventilation system. Every time I walk up to my clinic, I take the stairs rather than the elevator. And then I suddenly realize the stairs have no ventilation whatsoever. So I'm not sure that my choice of walking up and down stairs other than for exercise was a better choice than going on the elevator, quite honestly, because the elevators have ventilation.
Right.
But in any event, sometimes these are, yeah.
All right, and I think we got one more discussion question. And that is on vendors and other workers who need to enter the building. When we first started talking about this, I mentioned, those hospice reps and home health reps that used to come in. They're probably not necessarily coming in as much as they were before, but you do have to think about those vendors that are necessary. So say you have your fire alarm system test, it's due. You have to have them come in. How are they aware of what your policies are and what to do? Or your food service delivery folks, are they coming in the back door to deliver food? Are they going through the same screening process, or are they aware of your policies whenever they're coming in? So there are essential vendors that do have to still come in your facility, and it just needs to be clear to them what they are supposed to be doing as well. So if there's anything, yes, they know and are informed. Oh, rapid test. Perfect. And I've heard some facilities in this project, as well as the other I work on, that they have a video loop in their front lobby that talks about hand hygiene and proper PPE usage. And they must watch that before they come in if they haven't already viewed it.
I just added, Kelly, just the comment about a poster or signage at the point of entry to the facility. So some facilities have all the vendors come through a back door, which has no contact with living spaces, whereas others, they'll come through another door. But the one thing that we've noticed in kind of the reporting is that while there might be signage, sometimes the signage is not big enough lettering, particularly for older adults, not necessarily vendors, but for older adults. So making sure the signage is simple as possible for instructions as to where to go. Good.
And as we go through, you'll hear me refer to how do we determine the reliability of your system or your process that you put in place. And, I think it's very important that we make sure that we're asking questions of clarity to vendors, visitors, family members, just as much as we are to staff, because those folks can just as easily, or maybe even more likely, bring in the virus to your facility. And so we want to make sure what systems and processes you've put in place, they understand as well as the staff.
Yeah, and I would just also add, just remember that the rapid screening test is good for when the virus is at full steam. So those 3 to 4 days as people are starting to develop COVID, they've been exposed, they have a low level of the virus. Those antigen tests are going to be negative. So don't always think that they're like, just because they're negative, they're truly negative. You're going to find that people are just starting up their COVID infection. And it's important to have a tracer, right? So if you know how to contact the person, and also have the person contact you if they develop symptoms, so that you know about that. So there's always, as part of your policy of ingress and egress from the building, to make sure you have a registry of contacts for these people, so that it's reciprocal. So you can contact them and they can contact you. Should we go on to our next video for quality?
Well, good morning, good afternoon, or good evening. This is Alice Bonner from the Institute for Healthcare Improvement, and I'm going to present just a very brief, maybe about 5-minute overview of Quality Assurance Performance Improvement, or QAPI, for nursing homes. You're going to hear a lot more about this topic in later sessions, but today we're just doing a very brief overview. review to get you thinking about QAPI. Now, the regulatory development really started back with the Affordable Care Act, and there's been some subsequent survey and certification letters after that. And it requires CMS to establish standards and provide technical assistance to nursing homes on the development of best practices related to QAPI. And surveyors may ask for QAPI plans at any point during a survey or upon request. Some of you may use this guide. It's called QAPI at a Glance. It's a short guide, maybe about 20 pages, and it was developed at the same time as the regulations were being written. It's still up to date, and it is a useful tool to help any nursing home as they're developing and putting together their QAPI plan. So it's just a good guide, a good framework, and it may be useful to you. Now, there are a number of basic features to QAPI that are outlined in this slide. This really sums it up in a nutshell. QAPI uses a systems approach. It works to improve quality of healthcare and the residents' environment, as well as the environment for workers and care partners. QAPI is really data-driven. That's one of the key elements. And it doesn't wait until an adverse event happens. It's proactive. It involves staff at all levels, and it identifies gaps in the center systems or processes and continuously monitors the effectiveness of any interventions. These are the 5 elements of QAPI just listed on this slide. And so as you're going through the development of your QAPI plan, or if you're revising your QAPI plan, you want to make sure all 5 of these elements are in the plan somewhere and are addressed. So we're not going to go into great detail today, but just very briefly, each of the elements. So element number 1, design and scope. It's got to demonstrate that the QAPI plan is ongoing, it's comprehensive, involves all departments, and that it really focuses on person-centeredness and autonomy and choice. The second element, leadership and governance. This is really critical. The leaders of the organization, whether it's the board or people in leadership positions in administration and clinical roles in leadership, must all be involved in QAPI. As we said, this is a data-driven process, so getting feedback and having data systems that allow you to collect the data and to be able to analyze it, this is really critical, and to be able to look at adverse events in order to develop action plans and to do a root cause analysis for each of those adverse events. Element 4, which is about performance improvement projects, sometimes called PIPs. This is a way to identify where there are gaps and opportunities, how to design and prioritize PIPs, and how to look at the data as a result. And then finally, systematic analysis and systemic action just gets back to the notion that this is a systems approach. And after doing initial PIPs, go back and look at where you can integrate all of these approaches together and align all of them in a systems approach. And this slide just sums up, these 12 action steps for how to develop a QAPI plan. Very, very high level, but again, you'll see this in QAPI at a glance. It's just a way to frame the work to get started. And in addition to QAPI at a glance, we provided these other references and resources, which are on the CMS website. They're very helpful and gives a lot of examples of how to go forward. So that's all we have for today, less than 5 minutes. But if you have questions, this is my email. Please feel free to contact me. I'd be grateful to hear your thoughts, your ideas and suggestions, and answer any questions that you might have. So thanks for tuning in. Take care.
Great. Do we have any questions about that particular presentation? Again, you can either do in the chat box or unmute. So I think, given the time here, we're going to save this QAPI case for next time. Because we want to be mindful of the hour here. So if we can move on to the summary slides, please. So just to review that the QAPI, the first element is to have everybody involved as represented by that left part of the slide. The QAPI really focuses on 3 areas. So you should always have PIPs that are in alignment with these 3 areas of clinical care and safety, quality of life. So how do you improve, for instance, like do you have light therapy for people with insomnia? That's quality of life, improving sleep quality. So that actually would be a PIP. So that all the individuals that have problems with insomnia, that you apply light therapy to see if it improves their ability to get to sleep or to stay asleep. And then also resident choice. So that's a huge one, patient-centered or resident-centered care. And then also the other component of QAPI is to apply evidence-based medicine. So that's why somebody like myself as a geriatrician really wants to bring the best practices of geriatrics to the long-term care setting. And so that's based upon research that either we do or that we know about from the medical literature. Okay, next slide, please. So we need to make sure we know who the team is. I got spanked a little bit here by excluding the directors of nursing. In my previous slide, I didn't mean to do that. So obviously nursing, CNA, pharmacy, all members, housekeeping, dietary, they should all be part of the team in some form or another. You have to make sure that you track your policies and change them on a regular basis. I used to, as medical director, used to get a big stack of papers to review the policies at the end of each year. It should be a live, ongoing discussion. So as the PDSAs, the Plan, Do, Study, Act cycles occur and the quality improvement occurs, those policies should be changed in real time. Next slide. And so the other QAPI is you have to collect data. So firstly, you want to get feedback. The feedback could be from family members. It could be from the residents council, as well as from staff members. You can, when you do your huddle or walk rounds, there's a system where the CNAs that go bedside rounds with a nurse has higher quality improvement than just each person working on their own. You want to set performance standards. So what is the fall rate in the state of North Dakota? And how is your fall rate any different? What's the COVID rate? So we started off the COVID pandemic with North Dakota being the highest in the country in nursing homes in terms of the COVID spread. So that's a performance standard. Where are we now? And then to use root cause analysis, we'll do a little deeper dive with Kelly on root cause analysis using the fishbone diagrams and other methodologies. But certainly if there's an adverse event, wrong medication, somebody had an allergic reaction, or even a fall, those are all basis for root cause analyses. Next slide, please. Yeah, so that on the left there's what I was talking about, that fishbone using for root cause analysis. We'll get a little bit more instruction on how to use that tool. And then just to emphasize on the right side here is that as we develop our PIPs, that they do in a plan, you plan something based upon your root cause analysis. Let's say an individual, there was an increase in falls in the A wing. The question is why, and to investigate that, and then to plan an intervention to see if those falls can be reduced. So you do that, you study it, and you say, what we did seemed to work, so let's implement it. And that's the ACT part of it. Next slide, please. So the other part of systems change is to have continuous learning. That's what this process is, and to apply a root cause analysis. And so these sessions that we're doing are meant to be part of a live QAPI process. You can use these as part of your own, portfolio to say that you're involved in QAPI each afternoon as part of the learning process. So that counts towards your QAPI certification. Yeah, thank you. Next slide, please. And I just want to emphasize all these comments that everybody's making are just wonderful. This is part of what we call the coalition power. And so we want to use these sessions for real-time QAPI, more or less as a workshop for not only sharing PIPs, but creating your PIPs. So if, for instance, after today, you're able to create a PIP for the month of February, that would be a real good jumpstart.